and allows for detachment of the placenta postpartum. This is seen in ultrasound as a hypoechoic band. Loss of this hypoechoic band suggests placenta accreta. I want to show you on the left, in our normal patient, the hypoechoic band is present, and it's usually supposed to be thin and uniform. On the right, indicated by the arrow, the hypoechoic band is also present, but it's irregular and nodular. And as you approach inferiorly, it disappears. This is an abnormal finding. Our patient also shows large and irregular echolucent or dark spaces within the placental stroma. This finding is suggestive of cystic blood-filled spaces, also described as venous lakes or vascular lacunae. This is indicative of our patient's highly vascularized placenta invading past the decidua basalis uterine myometrium. This can indicate turbulent blood flow within the placenta. And on ultrasound, it presents as a Swiss cheese-looking placenta. So again, on the right, you can see the placenta forming midline, and the vascular lacunae, or dark spaces, are in the middle of the placenta. Compare this with the placenta on the left, where the placenta is uniform without any of these dark spaces. Again, this is an abnormal finding. These ultrasound findings at 20 weeks, 6 days gestation confirm complete placenta previa with features suggestive of placenta accreta. Placenta accreta is a type of placental implantation abnormality. These abnormalities differ by the degree of placental invasion into the uterine wall. They all pose for a massive risk of hemorrhage at the time of delivery. I want to show that we suspect placenta accreta in our patient currently, and that's when the placenta attaches to the myometrium. In placenta accreta, the placenta is within the myometrium, and in placenta percreta, the placenta invades past the myometrium through the uterine serosa and proceeds to go extrauterинely, where it can attach to the bladder or other pelvic organs. This is the most serious of the three types. Also present in our patient, again, is placenta previa, where you would see a placenta forming midline over the internal cervical os. This is another illustration. Three types of placental implantation abnormalities. Notice in each of these three images, you can see the presence of placenta previa. Also take note of the placenta invading past the uterus onto the bladder, in this case, a placenta percreta in the bottom right. You can see the bladder being invaded by the placenta. The most common of these three is placenta accreta, accounting for 75% of cases, followed by placenta increta, which makes up 18% of cases, and placenta percreta, which accounts for about 7% of cases. Placenta accreta occurs in 1 out of every 533 pregnancies. By some estimates, this indicates an increase by as much as in the past 50 years. This is likely to be associated with the increasing use of cesarean deliveries. Studies have shown that the most important risk factor for placenta accreta is placenta previa, in addition to previous history of C-section. Placenta accreta is theorized to develop due to the abnormal vascularization of the placenta during implantation on uterine scar tissue, secondary to cesarean section. This results in a loss of decidualization and allows for excessive trophoblastic cell invasion. This table shows risk factors for placenta accreta based on whether the mother is also showing placenta previa and the number of previous C-sections. Based on these categories, you can see that our patient presents currently at a 35 to 47% risk of developing placenta accreta. An additional risk factor important to consider in placenta accreta is maternal age greater than 35 years old. This currently applies to our patient as she's currently 4 years old. Around this time, an appointment was made with the maternal fetal medicine service at Massachusetts General Hospital, where the patient was seen for consultation of her ultrasound results. Were discussed and made with the patient. Maternal morbidity and mortality was also discussed with our patient. Placenta accreta has a 7.4% risk of mortality, which is directly associated with blood loss. 90% of patients also require a blood transfusion. Taking into account our previous C-sections and her second trimester ultrasound findings, doctors estimated the risk of developing placenta accreta in our patient to be 60%. Substantial risks associated with placenta accreta were discussed with our patient, such as hemorrhage, the need for blood transfusion, and possible ICU admission. Furthermore, options for minimizing the risks of life-threatening blood loss at the time of delivery were discussed. Our patient clearly stated her refusal of blood products, even if her life were in danger. An early third trimester ultrasound was scheduled to reassess placenta formation and signs of placenta accreta. In the event that ultrasound findings were unequivocal, an MRI was also scheduled. At 27 weeks gestation, the third trimester ultrasound confirms complete placenta previa with previous sonographic signs of placenta accreta. Follow-up MRI was not performed, under the belief that no further information would alter our patient's